Robinette. I'm a longtime faculty member at the Resnik Implant Institute. Randy had to be out of town tonight, so you're going to have me as your moderator. We will not have a lecture tonight, but we do have 9 cases to treatment plan. Helping me out tonight is Dr. Syed Ali. He's going to be helping us do all the treatment planning as we go through the cases, and we're going to go through all your CBCTs. As you can see, I used to be a pilot. I was a high risk taker. I used to fly 1,000 miles an hour at 100 feet off the ground. But when it comes to implant dentistry, I'm very conservative. I'm the exact opposite person. So are we ready for the first case, Saeed?
Yes, we are ready. So, Hussein, tell us, what do we
So,
have on
who's the
top of
first
our
doctor
list?
on our list today, Ziad?
It is Dr. Larry Briderman.
Dr. Larry Brightman. Could you hear us, sir?
Here we go.
Let's go to the second one. Ziad, I think we might be running a little bit late with Dr. Larry.
Okay.
All right. So next we're expecting Dr. Jared Lee.
I think we've got Dr. Neha Gupta. I'm admitting her right now, so let's possibly start with her case, and then we could get to those 2 cases later on with our session. Ziad.
Okay, that sounds good.
That is
Dr.
perfect.
Gupta,
So
can you hear us, Doc? Dr. Neha Gupta?
Do you want to start with Maria? She's here.
Perfect. Let's do that then.
Okay, let's go to Maria. How you doing, Maria?
Dr.
Hello,
Maria, you're on
hello.
mute.
Can you hear me?
Yes.
Okay.
Okay.
Sorry.
And one thing I didn't mention is on there's a chat bar at the bottom of your screen, and if you have any questions, go ahead and send your question in on the chat bar, and Dr. Hussein will answer the questions. All right, Maria.
Hello. Okay, something popped up. Do I hit share, open, cancel? All right.
Okay.
So I have a patient. We did, I believe, during one of our grand rounds, an implant on number 19. So now we're ready to do number 4. Beverly, in her 70s, sweet patient. We extracted number 3. Number 4 was previously extracted by an oral surgeon. Pretty healthy patient. Implant successful on number 19. I'm trying to get her to do number 3, but right now she just wants to start off with number 4. So even though I mentioned we might possibly do 3, presently she just wants to do 4. So I was thinking a 4 point, is it 4.3 by 11. On this side, you can see the bone graft that the oral surgeon placed. I placed the graft on number 3, but I'm not too happy with the result compared to number 4, but I would love to get your thoughts for
Okay.
future planning. Um,
Medications she's
yes.
taken.
She is on, and I apologize. I quickly logged on. I don't have my notes in front of me, but if I remember correctly, she's just on cholesterol medication. She's not on any contrary indication medication. Yes.
Okay. All right. Okay. So what don't you like about your graft on number 3?
It doesn't look as dense as number 4. I did use so that I believe we're looking at number 4.
So right here, Dr. Benefield, that's
Yes.
the
Yes.
graft at site number 4, blowing up the screen for you. That's
You
the
can see the
cross section.
graft really nice on number 4, but you cannot see it on number 3, which is the one that I placed.
Well, I
Yeah,
think your graph looks fine. I mean, it's you know, it's you're back there in that really soft bone that's basically styrofoam, and I think you're, as long as you undersize your osteotomy, cut maybe a drill or 2 or 3, I think you're going to be fine. Okay. One of the things that we discussed on yours is to try to talk her into doing 2 implants. So
Yeah.
all these cases we discussed with Dr. Resnik previously, and he really pushed 2 implants here so that you had more occlusal stability and you had more strength because of the being in the posterior like that. And you're on that very, very soft
Okay.
bone.
Oh,
I know she doesn't
yes,
want
and
it.
that way I can piece them together and give her better strength.
Yeah, and then you can split it and just tell her, with 2 though. I mean, it's like if you did 3. When I'm not saying do 3, but if you did 3, it's the third power, so that restoration is 9 times stronger than 3 single
Okay.
implants.
Very
So
good.
on 2, when you square it, it's 2 plus 2. I mean, so it doesn't make any
Yeah.
difference. But so you're going to be 4 times stronger if you splint those together. Okay, now when I went through what Carl would do sometimes, he'd sit there and say, if you can't talk him into it, and to keep it from failing, maybe do it for reduced fee or do it for free so that you don't have a failed case. Now, I'm not asking you to
I
do
love
it for free. I'm just
Right.
asking you to go back and say, hey, it's really important that we get you another molar in there. And I would explain to her, look, this molar was 3 roots. Okay. And now we're replacing it with one cylinder that's, maybe 40% of the size of the whole molar before. So we need more stability.
I love it. That's wonderful advice. I will definitely bring her back and just, sit her down and have a good conversation.
Okay, you have really good bone and you got good width, you got good height. I mean, I think everything's lined up for you. You're just back there in that really soft bone. And I've done some like in molars where they're so soft that I prep with the first 2 drills. Then I just hand pushed in uh, um, osteotomes to open the hole up and make it more dense. I mean, I didn't even hit them with the mallet. I just pushed it in to make it more dense. So that's something you might think about. So you just have to, get in there and feel the bone.
Okay. Wonderful.
Do you have anything to add, Zaid?
Yeah, I can. I think you've covered everything beautifully, Dr. Robinette. I think the only thing we can show Dr. Benefield is the implant proposal we've got, kind of to
Thank
show
you.
her the available bone width and height. So you've already covered the amount of bone height we've got. So right off the bat, we've got like we're planning for an SA1 procedure, no sinus lift procedure right here needed. Dr. Robinette mentioned the good quality and quantity of bone in terms of width and height. And the implant proposal right here on my screen. This is on the 3D. You can see, Dr. Benefield, that we've added 2 implants adjacent to sites number 4 and 3, potentially to allow you to splint these implants. We plan them to be perfectly parallel to each other in case you're considering stress distribution, as Dr. Robinette just highlighted. And when it comes to the choices of the implants, we wanted to go with ideal diameter and length. So for side number 4, we went with a 4.3 diameter, 11.5, as you were initially considering. You can see the fixture is covered with adequate buccal bone, lays slightly below the bone level. It's clear from the adjacent tooth, as you can see right here on my screen, and it's definitely clear away from the underlying sinus, keeping ideal implant to tooth and implant to implant distance towards the adjacent fixture. The neighboring implant, due to the slightly limited bone height relative to site number 4, we went with an 8 mm long fixture, also with good coverage in terms of quantity towards the buccal and palatal aspects, slight subcrestal positioning, shy of the sinus floor, and clear from all adjacent landmarks.
One,
What do you think? What do you think, Maria?
I love it. I love it. And thank you for that recommendation. I will definitely really encourage her to move forward. And even if we need to extend a payment plan or something
Yeah.
to help me with the longevity, especially with her heavy occlusal forces.
Yeah, I mean, you look how flat those are. If you just put the one in there, you might be eating that in a couple years.
Yes.
Then you got a big mess. And I like again, I would go back and emphasize that molar was 3 roots. Now you're putting in one circle. And
I love that. Love
okay. And Randy called your case the perfect case. He said because you have a lot of bone.
that. Thank you.
Yeah.
Okay.
And Dr. Robinette, about this case, he wanted to shed the light on one of the medication patient was on, the Lexapro.
Yeah, she said she's not taking the Lexapro anymore, is she?
Oh, yes, thank you so much. That was the other, I couldn't remember it. And that's why
Yeah.
I just got
Yes.
home from work and
Okay.
logged in. So yes, she is on Lexapro.
Okay.
Um,
Okay. And make sure 'cause that's a relative contraindication. Okay. Make sure that you get an informed consent that's telling her that this is a higher risk.
and can you remind me, I know we discussed it in complications, but remind me with Lexapro, what is the concern?
It's an SSRI
Mhm.
and just the bone stability.
Bone stability. Okay.
Okay. Okay. So that's it. Just,
All right. I will definitely have her sign consent.
yeah, for the relative contraindication.
A yellow.
Yeah.
Okay.
Okay.
Thank you.
Anything else?
No, this is amazing. I appreciate your wonderful leadership.
All right. Thank you. All right. You
Thank
ready for the
you.
next case?
Yes, sir, we are. Next case is for Dr. Tram Lee. Dr. Lee, would you mind please unmuting yourself and presenting your case to Dr. Robinette over here, sir?
Hi,
How you doing?
I'm good. How are you?
I'm doing well. Thank you.
So I have a case where for tooth number 31, I
Okay.
extracted the tooth due to caries back in January of this year.
Okay.
And then I grafted I think the bone graft that my boss used in the office is a little bit different from the one that it is recommended in the institute. But it still have some cortical and cancellous component. And yeah, so I took the new CBCT. It seems like she has really good bone. The graft looks healing well. Um, she has a very good arch, and I think Dr. Resnik did talk about like how sometimes like it's okay not to replace a second molar. Uh, for her case, I'm like, I feel like it would be beneficial for her to replace this tooth, especially because she have very straight teeth, very wide arch form, um, but this is my second implant for a while because
Okay.
the first one I did, Dr. Ali helped me with a guided case, and it turned out beautifully.
Okay.
But this one, if I have to do it, I have to do freehand. So I just want to see like, what tips you have or like what you could recommend, like how
Okay.
to approach this.
Okay. Can you put the cross-sectional view up on the screen, please?
There we go.
Okay.
This is the
So,
cross section.
so we've got a couple advantages here. You have a type 3 nerve, see how far down the nerve is, and
Yes.
you have abundant bone, and your undercut is not severe. Okay.
Okay.
Now, second molars, we don't replace them 50% of the time. One, people can do well with first molar occlusion. Two, it's
Mm-hmm.
difficult to get back there and try to stand the osteotomy drills up. And three, the nerve is a lot higher in that area, and then the undercut, it can be quite severe. So in your case, you came out with everything very favorable. Okay, so what Dr. Resnik recommended on you was to do this with a pilot guide, okay, and then do with the lateral aspect of it, and then go from there. That just to get you in a straight plane, and it gets you the good mesial, the good distance behind the first molar. Can you go ahead and place the implant in there for me, please?
Of course, there we go. So right here on the 3D, you can see the implant placed relative to the adjacent teeth on the
Mm-hmm.
cross section. Dr. Lee and Dr. Robinette, this is the
Yeah.
implant we're currently proposing. So we're
Yeah.
using a 7.0 millimeter
Yes.
wide fixture from Han Tapered. This is basically for demonstration. Could be
Yes.
replaced with a 6.0 diameter. It's engaging sufficient amount of buccolingual bone coverage. It's definitely clear away from that underlying nerve. We're placing it below the bone level coronally, as you can see in a slight subcostal position. And
Mm-hmm.
as we keep moving around it, it's safely away from the adjacent mesial molar.
I see, I see.
Okay.
Um, so I just tried to like kind of gauge the pilot drill
Yes.
from IDX, and I couldn't fit it back there.
And then that might stop you from doing the case, okay? Because
Yeah.
the one of the things that's the easiest to do when you have these second molars, because you can't see real good back there, you either end up starting the osteotomy too close to the first molar, but most often you set it too far distal to the first molar. You understand what I'm saying? So then you
Yeah.
end up with a huge cantilever. So let's just say you can't, you understand what I'm saying? So you want to
Yeah.
stay that, couple millimeters from that adjacent tooth. So I'd get her in. I would pull out your kit, your handpiece and your osteotomy drill, and let's see if you can stand it up. And if you can't stand it up, then I wouldn't try it. If you can stand it up, and you get the pilot guide, and let's just say on your drill kit you have a 17, a 21, 24, and 28 depth. I'm just pulling out numbers, okay? And and they tell you to use a 21 depth, and you can't get it back there. Try making the osteotomy at 17, and then come back, and now you can make it at 21, and then because you already have a hole. Does that make sense?
I see. The one that from I actually purchased the one from IDX Pro.
Okay.
Like that's the pilot drill. I
Okay.
think you guys have it. So Dr. Ali, you have in different length for the pilot drill?
Yes. So yeah, so the shortest, it's very close to what Dr. Robinette right here just mentioned. The shortest drill is an 18. I think what also Dr. Robinette brought to our attention, luckily, is that usually with these systems, these universal systems, you can get like a side loading surgical guide that allows you to introduce the drills from the buccal aspect towards the patient's cheek. This could be a very, very helpful tool when dealing with limited mouth opening or sites that are too posterior with bad accessibility.
Yeah.
So I think this is something that we can
Oh.
definitely consider with this case.
Yes.
Oh, with the buckle aspect. Okay.
Yeah, and yeah, because you're going to have a window in the buckle aspect of the guide, so you can just slide right in there. That gains you 3, 4, 5 millimeters right off the bat.
Oh, okay, that's good.
So that makes it almost a freehand case.
I see, I see. Because it can open really wide, but then like, when I try I guess my pilot drill is really long too.
Yeah, it could have been. Yeah, I would go to a shorter one. So like in your case, if it's an 18, if let's just say he puts down you need a 23 drill and you can't stand the 23 up, drill the 18 first, and then you'll be able to drop right in that hole. And the biggest thing I can caution you on second molars, take your time, because it's
Yes.
too easy to get that thing leaning way. You can make a mesial tilt on that without batting an eye, because you can't see, and there's just no room. They're closing down, and you're just doing the best you can. The next thing you know, you've got one going at 25 degrees or something like that.
Got it, got it. Okay, so
Okay.
definitely it's gonna be like a pilot drill
Yes.
case with the
Yes.
buckle
Well,
aspect
yeah.
and then yeah, and then complete osteotomy for rest. Okay.
Yeah. So before you invest all the money, I'd bring him in, put your drill in your handpiece, and then just see if you can stand it up. Okay. And that
Okay.
way, if you can't, then it's, hey, you tried, and you get an E for effort.
Okay. Okay, got
Okay.
it. Yep. Thank you.
Okay.
Yep.
Okay. Thank you. All right, Zed, you ready for the next case?
Yes, I think we are. Hussein, who do we have next?
Thank you, gentlemen. Next case is for Dr. Neha Gupta. Dr. Gupta, would you mind unmuting yourself and presenting your case to Dr. Robinette, please?
Hi, Dr. Ravnit. How are
Hi.
you?
Good, and you? It's
Doing
nice to
very
hear.
well,
It's
sir.
good to hear your voice.
Yes, likewise, sir. So I have a 44-year-old male over here who actually came to me asking for a crown on tooth number 8. I recommended extraction and implant restoration for tooth number 11. And I do see that he is missing 14. So I was planning implant restoration, but in the CBCT, if you can notice, I see a big, like some pathology in the sinus.
Okay.
So
Okay.
I'm
Well,
not sure. So my concern is like if it's tooth number 11 is a good site after extraction, should I plan some GBR for that site for optimal aesthetic result? And then how about 14?
okay. Can you So this is the one with the, okay, yes. Thank you for pivoting around, giving us the 360 view. So when you, earlier when we were going over the case, you had 4 sets of eyes on this case. Okay, on your number 11 and
Yes,
your cross-sectional view,
Mm-hmm.
there are a couple white dots right there.
Yes.
Okay, what are those white dots?
He
All
has
right.
no restoration.
Yeah. And Dr. Z and Dr. Hussein actually figured this out this afternoon.
Uh-huh.
Okay, so we were like, is that some atopical root, I mean, tooth that never formed? You know, what is that? And this is where on the CBCT, you got to take your time and look at the entire thing. So in the axial view right here, I want you to look at this. So look at your canine. Look at the palatal root on the first premolar.
Yes.
So what is that? That's your palate. Those white spots you're seeing are your palatal root up against that canine.
Right. Yes.
Okay. So now, I mean, so that's something, like I said, we were all stumped when we first looked at it, but they did their homework and found that out. I mean, we were measuring Hounsfield units and everything like that. And I think that came in at 2,300 plus. And as Dr. Resnik said, anything over 1,000 is not bone. Okay. But so in this view right here, look at how that root curves right into that implant.
Yeah.
Okay. So what is your solution now that we've pointed all that out to you?
Should we? I have no clue, sir.
Okay. So I think you're looking at a bridge.
Okay.
Okay. Because Dr. Z and I, we talked about this. We played with doing the GBR on the facial and everything like that. You're going to end up too far facial. So, because I mean, so you got that nice catcher's mitten there, and then we played with that, and we positioned the implant out to the facial and everything like that, and it just didn't look. It didn't work. So, unfortunately, with this case, because of the way that root curves back into there, you're going to be you're a bridge.
So if the patient did mention he might be interested in some ortho, so do you think if we do ortho first, that might be, we might be able to get some room for implant?
If you're going to do that, are you going to do the ortho? Are you going to work with an orthodontist, or what are you going to do?
I mean, we can do either based on your recommendation. I was planning on doing Invisalign for him.
Okay. I was going to say, if you're going to try to do that, I'd talk to an orthodontist and I would go to bands. So because you're going to have to translate that tooth. And so that's going to be a big bodily movement where, you know, where the Invisalign and things like that, it's a lot of tipping. You know, it's not the translational. Yes. So if they insist on an implant and you want to go down that road, you know, just warn them it's going to be banding and you're going to try to move that tooth back.
Got it.
Okay. And you got plenty of room in the molar area to be able to slide those two teeth back, and you can put another premolar in there you wanted instead of a molar. Because you're not going to have to go but a couple millimeters.
Yes. And should I be worried about the pathology I see in the sinus?
Yeah, that's the next thing that we talked on. Can you give us can you measure the height of that retention, that mucocil for us? I mean the pseudocyst for us.
So right here, the mucus retention cyst at the sinus adjacent to potential implant sign number 14 is a little bit more than 10 millimeters. So I would say that's 11 millimeters in terms of vertical height. Okay, so anything below 10, you can just proceed ahead. Dr. Resnik was saying, and it's in his book, anything over 10 millimeters, you're going to have to refer to an ENT.
ENT, yes.
Okay, and let them take care of that. Dr. Resnik in his forms has sample letters that you can use. They're very good. I've used them for a lot of ENTs, and they really like them. When I send the ENT, some people send the whole DICOM. I make it easy. I screenshot this. Okay, and I make it a whole page. I don't, make it a little teeny tiny thing. So I screenshot this and send them the whole thing. So now you've taken care of the cyst and the ENT's given you the go ahead. So you have a height of bone of 4.5 millimeters. So what is your cutoff between an SA3 and an SA4?
5 millimeter.
5 millimeters. And as Randy will go on and on and on, 4.9 doesn't get it. Okay.
Yes.
So if the ENT gives you clearance, and he's probably going to give you clearance, then you're going to do an SA4. And when you go into that cyst, you're going to drain it because it's just inflammatory cells and serous fluid.
Got it.
Okay. Does that answer that?
Yes.
Yes. Okay. So we have an implant. Can you show us the implant you designed, you prepared for it?
Of course. All right.
Yes.
So right here, Dr. Gupta and Dr. Rubinet and everyone on the meeting, you can see that we've designed an implant right here at slide number 14. Through the edentulous ridge, we are perfectly aligned with the adjacent teeth. We're centralized buccopalatally and mesodistally. And the most important thing relative to the available bone, like at the alveolar portion, we have good width to accommodate a big implant, also considering like a 6.0 diameter. Scrolling around the long axis also to see the mesodistal dimension. We can see that with such a big implant right in there, we still have sufficient amount of room towards the laminatures of the adjacent teeth. So considering that the bone height is limited, we're going with a big implant right here. The crown to implant ratio is not very favorable. We wanted to go with a bigger fixture just to compensate for any added force or biomechanical factors in the future. And this is how it looks.
Does that make sense to you?
Yes, doc.
Okay. So if you decide to go the ortho, you're going to bodily move that tooth, I would deal with an orthodontist, okay, and to see if they can do that. Okay. See, just remember that number 5 and number 12 are the two worst teeth in the head. They split easily, so you got to be careful changing where you put the occlusion in on them, so you don't split them down the middle. I do more immediate implants on 5 and 12. I got a whole library of those two teeth that have been split.
Okay.
Okay. Does that take care of that? Does it make sense? Okay.
Yes.
All right. Thank you for the interesting findings of that root tilting back.
I know. I totally missed it.
Okay. Well, like I said, the 4 of us looked at it, previously, and we didn't know what it was, and they did their homework today, and they figured it out. So, all right. Thank you.
Thank you so much. Appreciate it.
All right. All right. Okay, Ziad, we're ready for the next one?
Dr. Mahima Gupta is our next one, Dr. Robinette and Dr. Z.
Okay.
Dr. Mahima, would you mind unmuting yourself and presenting your case, please? Dr. Mahima, are you on the phone with us?
Yes. Are you looking? Okay. Yes. Sorry, I was trying to unmute.
Okay.
No worries.
I've been there. Trust me. I can't get it to unmute. I can't get it to. I can't hear. Trust me. I had that yesterday with Nuran when I was trying to have a webinar with her. I couldn't hear. So I understand.
Okay. So I unmuted myself. Perfect.
Okay.
Okay. So my case is, we already kind of planned the case. I just wanted second opinion on this case, if it is looking right. My initial plan was to give anterior implant on 7, 8, 9, 10 are the very compromised one. Thought process was maybe I can place an implant at 7 and 10 and maybe make a bridge. But because there is not much bone loss, like not bone left and all that stuff. So I was like maybe going with canine to canine, make a bridge, and then do the grafting at 12 and 13 because they are very compromised. I cannot get immediate implant at all. And then go back in future, place an implant like bridge from 12 to 14. So then I will have total 2 bridges, 6 to 11, and then 12 to 14. So just one second opinion, if I'm thinking right, like should I stick to this plan or should I just make like a 1 unit bridge all the way from 6 to 14, or should I even do all on X? So that's where I am.
Okay. So
like what will be the best for patient? Okay.
So, first impressions are everything. Okay. So when I look at this view that you have here, what my first impression is that on mandibular, you have a 2-step bite and you have severe dentoalveolar extrusion. Okay. I think that's going to cause you problems. And can you show me the lower, the mandibular arch around those anterior teeth, please?
Actually, lower, we have already fixed it. So lower.
Yes. Have you already taken them out?
Yeah, we have taken them out and placed 3 implants on the bottom.
Okay. So you took the anterior out and you've leveled the bite off.
Yes, I did.
Okay, all right, then that changes a lot then. Okay, so let's go back then to see, because you had no bone and anything like that. So you got good implants in there, and you did a 4-unit bridge down there.
I have done the restoration part. I just finished the surgery part.
Okay.
So yes, I did the surgery. I was able to get the implants pretty decent, and I did some autogenous bone from mandible and transplant. A little bit like did the buccal grafting on the
Okay.
mandibles.
Did you take out just the 2 incisors, or did you take out the 2 canines too?
I think we took out one canine.
One canine, number
Yes.
27. Okay.
Yeah.
Okay. All right. So then let's go back to the. Can we see the maxillary arch, please, in a panoramic view, please?
Where shall we go on Robin?
Okay. So we at one time did hands-on at Temple. Okay. And when we got done, Carl happened to be there. Carl was never there, and he happened to be there that day. And he took us all into a room and hit Carl's nicest voice, said to us, don't place implants if there's any infection. So he's saying what he would say here is you got to get all those teeth out at one time that are infected, that are compromised, that you don't think are going to last 5 years. So I would take out 8, 12, and 13 before I did anything else. You might have to do a partial up there, and then I'd come back at 3 months and I'd reevaluate, because I think in the 12 and 13 area you're going to find out that you don't have much bone up there at all. You've got pretty good size abscesses. See, look at that right there. That's pretty good size. That one you'll be able to wiggle that one out easier than a baby tooth, probably. And then when you go in there and you curette that, be careful not that you don't go into the floor, but I think you're all right. And I'd be willing to bet you $100 that when you got down to that abscess, it's either going to come out on the tooth or you're going to be able to pull it out in one big chunk with like cotton pliers. Have you ever done that when you had the big abs? Okay, I think that's going to be your thing. So what I would do you have a laser, don't you?
I do.
Okay. So can we blow the panoramic up again? Okay, so I see some bone loss, some other teeth. What are you going to do? So you're talking about taking out 8. Are you talking about 9 and 10? What are you going to do with those?
That was my original plan, to keep the canines, move the lateral to lateral.
Okay, so you're going to keep the canines, and then you're going to take out the other 3 anterior teeth. Is that? Am I assuming this? Okay. So what I would do, since you have a laser, you got a head start on everybody, is I'd get the 5 teeth out. I'd wait 3 months, and I'd go in there and laser and make sure that I'm killing all the bacteria in there. Just do your razor, your nap procedure, and get all that infection out of there, and then come back and then start doing your GBRs, because you're going to have a problem in the anterior, is you're going to have to gain a lot of height. What does that number 8 look like in a cross section?
Let's go
really bad.
Cross section of
Yeah.
number 8. This is how it looks, showing
Okay.
periapical and periodontal
Pros-
breakdown with
yeah.
very limited available bone.
Like
Yes.
I'm almost having doubt that I can get this much regeneration if
Yeah,
I just do the extraction and delay.
Yeah, it's going to be a very difficult case. What's 9 and 10 look like, please?
All
Almost
so we
same.
crossed the midline.
Almost the same.
And
Yeah.
number 9.
Yeah.
That's why I was thinking to go with like immediate implant on 6 and 11 and graft the whole spot as much as I can.
Okay. Can you go back and show me which tooth does that have that really large infection down there?
That's number 9.
9? Yes. I mean, you have 0 there. You almost have negative. I think you really got your work cut out for you on this one. Can I see the cross section on 6, please?
So this is the cross section on number 6. Key
Okay.
takeaways: we've got some bone loss,
Yeah,
periapical radiolucency,
Yes.
very thin labial plate.
Yes. Yeah, you're in kind of a tough spot. Okay. I think what I would do is I would extract 6 to 11 and 12 and all the way to 13, and then I'd reevaluate in 3 months to see how you healed up. Because you got the infection on 6. What's 11 look like? I mean, you've got bone. 11 looks decent. The one
Yeah.
thing is, you really don't want 2 implant bridges. Maybe it's better to just have one big implant bridge if we can get any bone back there. But a partial denture might be the future. I hate to say it, but that might be. So you could clear up the infection on 6 and do a partial on 8, 9, and 10. I've seen in my lifetime, I've been doing this for 44 years. I've seen a lot of bridges from 6 to 11 do okay for so long, but I do more big bone grafts on big bridges. And it's because then when they fail, then now you got the biggest mess. Am I making sense?
Yes, you are.
Okay, so it's a tough. So I would take out. I'd make some kind of temporary partial, and then I'd reevaluate. The fact that you'd already fixed the mandibular, that makes me very happy, because that was the first thing that stuck out in my head. Do you have anything to add, Zia?
Yeah, so I think, Dr. Bennett, the only thing that you also shed a light on when we were talking about this earlier is the
Yeah.
hypertrophy. Yes.
Yes. Yeah, go ahead, please.
Yeah, the hypertrophy in the nasal concha and the proximity of the maxillary molar and premolar roots to the sinus, which might be a cause of the nasal infection, risking odontogenic rhinosinusitis, and also necessitating a referral to ENT due to the blocked nature of the osteum.
Yes. Yeah, we couldn't see an open ostium there. Yes. But you get 12 and 13 out of there, and you're not going to stop the hypertrophy, but I mean you're going to clear up a lot. But that's definitely an ENT case.
Okay. Thank you for pointing that. I'm going to definitely refer him to ENT to get it looked.
Okay.
Anything
else?
No.
All right.
No.
All right.
Thank you so much, Doc.
Thank you.
Bye.
All right. Hussein, what do we have next?
Gentlemen, our next case is for Dr. Rusha Fatima. Dr. Fatima, would you mind unmuting yourself and presenting your case, Dr. Robinette, please?
Hello, everybody. Thank you for your time.
Thank you.
I have patient Glinda. She has multiple teeth missing, 4, 5, and anterior 8 and 9, and she has a root tip on 11, and number 7 and 10 is non-restorable. So there's multiple teeth that are missing. And then her lower anterior prosthetic space is a bit compromised. I was planning to place 4, 5, 7, and 10 and 11 implant positions, and temporizing with smile transition. So
okay. All right. Can you give us a 360 view of the maxillary arch, please?
Just wanted to add, sorry, I didn't mention medical history is clear. Patient, she's a female 70-year-old. She only takes a low dose of water pill.
Okay. Very good.
Thank you.
All right, you can see, you're starting to see over here in the premolar, see how you've got a lot of horizontal defect?
Yes.
Okay, and then you look up there at your maxillary anterior, and when I talk to a patient, I do all my treatment planning in front of the patient. I mean, they see me open the x-ray, they see me set it up, and I do my treatment planning right in front of them, and I explain to them what I'm thinking about. So one of the things I tell the patient is I have to have 8 millimeters of width and 8 millimeters of height. So when I look at your maxillary anterior, I don't see 8 millimeters there. How much width do we have?
So going to site number 8, Dr. Robinette, that's the cross section. And we take a measurement right here for Dr. Fatima, and adjacent to the coronal aspect of the bridge, we're talking about approximately 5 millimeters of bone width with slightly flared labial angulation.
So you're 3 millimeters short already. Have you done many tent grafts?
No.
Okay, they're really easy. People get spooked by them, but they're really easy and they work very, very well. So let's go back, and we have a question on number 6. What is your prognosis on number 6?
It's a root tip, non-restorable.
Yeah,
And
I think Dr.
buckle
Fatima, you're
plate
talking
is
about
very
number
thin.
7.
7.
Yeah.
Yeah.
Yeah, so we're
Yeah.
considering number 6 right here, that big
Yeah.
canine that
Oh,
is
Yeah.
6.
right in the
Yes.
middle of
Yes.
the implants you're planning on
And-
either side. So we
Yeah.
wanted to ask you, yeah.
Yeah. So when you notice right here, if you notice, it looks like, that half that tooth is sitting out of the bone. Now we
Mhm.
know that there's a half a millimeter of bone that we cannot see on a
Yes.
cone beam. So there's probably a layer of bone over there, but you're going to have, that's not the best tooth in the world.
Yes.
We spent quite a bit of time discussing your case. We did it with all the cases. We spent time, but one of the things that Dr. Resnik kept pulling out with is, do you want to do 2 implant bridges or do you want to do 1 big one? And what he was stating was that there's more stability, more occlusal stability by doing 1 big bridge. So in that case, we would take out number 6, and we would do a GBR from 4 to 11, because number 11's in really bad shape.
Yes.
Correct? It's So you might have to.
So we'll go to 11 right here to show
Yeah.
everyone how does the
Yes.
current status of that tooth look. So we go to the cross section and we're blowing that up for everyone to see how 11 looks like. So it's a remaining root right here, almost at the bone level, with barely any labial bone covering that side.
Yes. And that's going to be a difficult extraction for you. One of the things I did the other day, I had a hard time getting the canine out. I cut the tooth mesial distal right down the middle.
Okay.
And then I used the Meisinger burr, that long thin one. At one time it was called the Pico's burr. I don't know the number on it, but it's that real thin long burr. So I cut it down the middle, and then I took out the lingual half, and then the facial half just came out real easy for me. So I wasn't in there struggling, because you have nothing to grab a hold on. So you can take your periotomes and work and work and work and work. But try that, splitting it in half, and see see if it doesn't help you out.
Okay.
Okay. So what I would do with yours, can you go back to the axial view for me, please? Okay. I think this is an outstanding GBR case. This is one that I was talking about earlier. You get the people to get a lot of bridges, and then they end up with nothing, and so you got to build them back, and they seem like there's always 80-year-old women. Okay. But if you look at that, if you look in the premolar area, I mean, you have a nice concavity there. 10 screws would work out really, really easy. Okay. I would probably go 9 millimeter. I'd probably put maybe 3 9 millimeter screws in the premolar area, and I'd either do 8 or 9 millimeter screws up in the anterior, and basically, I'd probably put 1, 2, 3, 4, 5. I'd probably put 5 screws across the front.
5 across the front, and how many in the premolar region?
2. I do 2 to 3. So you're probably looking at 8 screws and everything like that. Okay. So when I do these cases, one of the things I do first, so I go in there, and after I flapped it, I make sure there's no granulation tissue there whatsoever. I mean, you got to get rid of every bit of granulation tissue to it. So don't hesitate to take an acrylic burr or something like that to get that granulation tissue off. Then I come back and I use the drill for the Salvin tent screws, and I just start punching holes. Okay. I mean, it looks like Swiss cheese when I'm done. Actually, I mean, the holes there's a ton of holes. Then after I have my holes drilled, then I start looking at where I want to put my tent screws, and to make sure that you don't want the tent screws parallel to each other, so you don't want them all sticking perpendicular. Just put a little angle to them or whatever. And I think you're going to end up with a great case. And I think it's one that when you're done, you'll go out and drink some champagne.
Okay. Dr. Robinette, can you just walk me through the steps? So with the temporary smile transition would work on this
Yes.
case?
You could.
That will work.
You can do that, or you can get you got to be careful about flippers and things like that, because you can't have anything on the buckle.
Okay.
Yeah,
Yes.
so the small transition will work very well. You got good molars there to help hold it in place.
Okay.
I think you'll do fine.
And then
I,
you Mhm.
go ahead.
Go ahead. I'm sorry. You can finish,
Okay,
then I'll ask.
I would just tell them in the beginning that you're conservative and you're going to do a really good job. It's going to last, but from the
Mhm.
start to finish, you're probably looking at a year.
Okay. Yeah. So the first appointment is going to be to remove 6, 7, and
11.
10
11
and 11.
and 10, right? So
Yes.
I'm
Yes.
removing all of those and then doing decorticating, taking all the
Yeah.
granulation tissue out, all of that, and then
And you,
grafting at the same time, right?
yeah, I would do, yeah,
PBR, 10 screws all at the same time.
I would. Yes.
And then I would leave her for probably five 5 months at least.
I'm 6 months minimum.
6 months. Okay.
Okay.
So
I
okay.
found out at 5 months, it's just still too soft. And a lot of times at
Okay.
6 months,
Six
it's
months.
soft. Yes.
Sounds good. And then then we evaluate again to see where we're going to put the implants, and you want me to do a bridge starting from 4 all the way till 11. Is that
Correct.
the plan? Okay.
Okay, so what I do at the 5 month point was we bring him back. We take another CBCT.
Yes.
Now we can see that we get our width. Okay, and if you have good passive closure of your flap,
Mm-hmm.
you're going to get your width. I grow
Okay.
4 millimeters all the time, and you're going to grow your 4 millimeters, and especially in that premolar area when you have that big concavity, that's going to be a
Yes.
walk in the park for you.
Okay.
And Dr. Resnik has those 8 steps all outlined for you for bone grafting. I would just
Yes.
follow the,
Yes. And
yeah,
I'm
just
going to be there in July for the GBR course as well.
okay. That'll be good
Mhm.
for you then.
Yeah. And I'll plan this right after. That'll be, yeah.
Yes, ma'am.
Thank you so much.
Anything else, Saeed?
I think you've already covered everything, Dr. Burnett. Maybe the only one thing that we can share with Dr. Fatima would be a glimpse of the final plan for this case.
That'd be
So
great.
after you go through these phases, Dr. Fatima, you'd be considering multiple implants right in here. I know they look like they're all over the place, but what we're considering with this placement or with this distribution is basically trying to place sufficient amount of implants at key implant placement sites. So actually,
Mhm.
Professor Resnick's recommendation was placing 2 implants at 4 and 5, definitely doing one at 6 as that now that we're delaying or staging the case, doing 2 anterior implants at 8 and 9, and definitely at the terminal side of number 11. The one thing we wanted to share with you is that upon placing some sort of diagnostic wax up right here, you can
Mhm.
see following the angulation of the available bone how flared the emergence kind of seems. We're
Yes.
emerging through the labial aspect of the teeth, which puts more emphasis on the need for the GBR and the augmentation to be able to
Yes.
place the implants at more predictable restorative positions and
Mhm.
eventually to get more predictability on the case. So this is
Okay.
what we wanted to briefly share with you, the key implant sites, the distribution and everything, and the
Okay.
emphasis one more time on the need for the augmentation.
Okay. I have one question about small transition. I've already ordered it. So number 6, I could just fill that with the composite, right?
I filled in
Just
with
start with
composite.
composite and just use it. Okay.
Yeah,
Sounds
but
good.
what I would do is I would get them to send you an STL file of this model right here, and you have a printer. Do you have a 3D? You have a 3D printer?
Yes. Yes, we
Okay,
have.
and I would print the model and I would show them how nice that looks.
Okay.
Okay, and you can even do a suck down over it, and then take that to the mouth and put your temporary crown and bridge material in there, and show them how good that would really look in the end, and
Okay.
that will motivate them.
Sounds good. She already paid. I'm afraid now.
Yeah,
Ready
but
to go.
you got to tell her
So good.
though.
Yeah.
You've gone, just tell her you've gone back and studied the case,
Okay.
and you want this to last, and you only want to
Yes.
touch it one time.
Yeah.
Okay, and you don't want it to fail, and you want it to look really good. So you're by making this one big bridge, you're making this stronger, and then he
Yes.
can do more with your restorative by lining everything up, because now we're starting with a fresh playing field.
Definitely. Definitely. Thank you so much.
Anything else that you?
Yeah, I think you've covered everything, Dr. Rubinet.
Really
Okay,
appreciate.
yeah, you're welcome.
All right. That is perfect. So let's get ready for the next one.
Great. Next case, Dr. Robinette, and Z is for Dr. Kaylee Tensley. Dr. Tensley, would you mind please unmuting yourself and presenting your case to Dr. Robinette?
Hey, good afternoon. Can you guys hear me?
Yes, we can hear
Loud
you
and
loud
clear,
and clear.
sir.
How are you doing?
Doing fantastic. Hope you guys are.
You're doing great. Thank you.
I'm preface this with I'm still pretty early in my learning curve. I've only placed a few implants so far. So really my biggest question with this case is the quality of bone. So I saw this guy March of 2025 last year. He had a bump on the gum, a little sore, and he had number 13 was previously root canal treated. I sent him to the endo. He retreated it in July. Never healed, kept getting, it actually got more infected, more bone loss around the apical. Excuse me. And I extracted and grafted it in January, which was before I knew about the Cefazolin trick, and had taken Dr. Resnik's first course.
Okay.
I saw him in April and took a cone beam. It didn't look quite ready. It'd been about 4 months. And so I just saw him actually yesterday, took another cone beam. And again, it's not as complex, I don't think, as some of these other cases that have been really interesting. But I'm just really curious because I have two cases back to back that are almost identical, just in different locations. And I'm curious. Sorry about the background noise.
That's all right.
I'm curious about the quality of this bone and how it's healing, especially with that much infection that was up there. It was so much.
Okay. So before we discuss the bone quality and everything like that, you've answered some of my questions. I'll come back. Saeed, can you go ahead and show us what the implant and the restoration would look like, please?
So right here in the 3D, blowing the image for you, we have proposed an implant at the site. This is how it's currently emerging. Centralized mesiodistally and buccolingually through the edentulous ridge, like perfectly in line with the central fossa of the neighboring teeth. And taking you to the cross section right here, we're proposing a 4.3 by 10 implant, plenty of buccopalatal bone coverage in terms of quantity, mesiodistal space perfectly adequate right here, clearing the adjacent teeth and also safely away from the underlying maxillary sinus.
What do you think? You like that?
I think it looks great. I'm just I'm curious about getting in there and it being a little mushy. I was thinking about doing like um bone like osteotome and kind of like solidifying the bone around it a little bit if need be. I was questioning some of my perio friends about it and seeing what they would think, and that's kind of what they were saying too.
Okay, so you answered my first question that I had written down on the notes. So you had a big infection prior because you had a fistulous tract, correct? Unmute yourself. You've muted
There you go.
yourself.
Sorry, that's correct.
Okay. All right. So the next thing is how many months ago was it? It's been 5 months since you grafted?
Yes, sir. I grafted in January.
Okay. So we discussed this one at length, and what I would do is I would wait one more month before I even opened it up, and then I would definitely flap this site. Okay. Now, when I say flap it, my flaps are pretty conservative. Okay. So I lean towards the palate a little bit on my crestal incision, and then I basically only relieve the interproximal, and I just open the flap enough to see the buccal and lingual bone at the same time. Does that make sense?
Yes, sir.
Okay, so don't do a tissue punch on this. Then when you go in there, look and see with your curette and see what you have. You might be surprised. It might be more firm, but if you can take a curette and you start spooning that bone out, then I'd clean the whole thing out and start all over again. Okay? Do you have
okay.
Okay. So I let that curette kind of be my guide.
Just like a cavity.
Just like a cavity. It's like you're doing a spoon on decay. So you go in there and let's say the curette doesn't remove anything, a little granulation tissue on the top, but it doesn't really go deep. I would go 2 drills max. On yours, I probably wouldn't do the osteotomes. I'd go 2 drills and just go ahead and put the implant in, because you'll get the density by putting the implant in with only those 2 drills. So you won't have to pull out your osteotomes.
Okay. Okay. So if I can't spoon it, you're saying just go for it.
I say, well, we said, yes, that's what we 4 of us came up with earlier. I'd go for it.
I love it.
Okay. Okay, because it might be better. You know, when you're drilling it in it, and when you're drilling in it, it's like, oh man, this is just super soft. Then maybe you back up and you clean it out and start all over again. But
What
go ahead.
um what would be the consequence of going in prematurely? Like would failure be a consequence or just extremely prolonged osseointegration?
What I do is I try to always give it 6 months, and I just cross my fingers for the last month. Okay, I mean, you know, cross my fingers and my toes, and hope it looks a little better. But you're just giving it more time to heal, because you remember that the bone healing cycle is 1 year. Okay, for it to complete the cycle,
Right.
and we're gaming the system by going back in at 6 months. Okay, so I let that curette guide me. Then when you start putting those drills down, I mean, and like if it's super soft, did you do the lab where you drilled into the styrofoam balsa wood?
Yes, sir.
Okay, if you're getting styrofoam, then maybe you want to clean it out and start all over again.
You got it. And then
Okay.
same waiting period.
Yeah,
after
6 months again.
regrafting.
Yeah. And I asked that to Randy when we treatment plan these. I'm a real hardcore 6 months. When I first started out, we were 4 months. Then we went to 5 months, and I'm a real hardcore 6 months. If they're 85 years old, I might even go 7 months. Okay, because remember, it takes a year.
Yeah, that sounds great. Yeah. Okay.
Okay, but you got a great site. It's just maybe managing it.
Just a little patience.
A little patience. It's just like I said earlier, I'm very conservative, but I opened that up, and there's been a couple on molars. I've gone in there with a curette, and I tunneled all the way down. But let's say outside of a 2.0 drill, it was hard. It was hard, but right down the middle, it wasn't hard. You know what I'm saying? So I went in there and cleaned it out, and then opened it up.
Sounds good.
Anything else, Z? Do you want to add?
I think you've already also covered everything. Maybe one thing I can shed a light on with this case right here is that probably that intensely during the extraction, you've done it in an atraumatic way that actually preserved the labial plate of bone, which is one of the very good key determinants for predictable bone regeneration rather than haphazard repair. So although the size of the root is large and it's going to take a lot more time to heal, but still, I think with your extraction, with the anatomy of the remaining socket walls after the extraction, you provided a lot of input for good healing. And this just emphasizes the importance of the extraction at the time of root removal or tooth removal and the importance of the socket preservation you've done right here. So that's the only thing I wanted to shed a light on.
Thank you. Good to, yeah, that's good. I know it was I know I tried to remove as much as I could, but it was like 11, 12 millimeters, and I think I remember burying my curette all the way down, and I just was like, okay, I don't really want to go any further and just keep scraping.
Yeah, but he's right. You got great cortical bone. I mean, that's the game changer.
Sweet. I can't wait.
All right.
All right. Any more questions? Okay, thank you. Next case, please.
Next case, Dr. Robinette, is for Dr. Oana Cornu. Dr. Cornu, would you mind unmuting yourself and presenting your case to Dr. Robinette, please?
Hello.
How you doing?
Hello.
I'm fine, thank you. Thank you so much for considering this. My patient is Amy. She's in her 50s, very healthy, and no medication. I already placed an implant in number 2 side, and she would like to have an implant in number, oh my God. I'm so
15,
sorry.
is it?
It is before they send the CT scan before the extraction. I extracted number 15.
15, okay.
And it was bone grafted. I bone grafted. It looks really good, and the patient would like an implant in the 15 site, but I'm having a problem because of the sinus.
Okay.
The sinus is extremely large.
Okay.
And the width, the mesial distal, I have about 5.5 millimeters
Okay.
in between the sinus and the root of 16.
Okay.
And so I know there is no sense of placing a 3 millimeter implant in there. And I would like to know, you see, if you look at 15, you see, unfortunately, the CT scan is before the
Yes.
extraction was performed. So my assistant did not load the right CT scan.
Okay.
But my idea is, what do I do in a situation? I have enough width buccal lingual,
Okay.
but I do not have mesial distal more than 5.5 between the sinus and the wisdom tooth.
Okay. Can you try to put us an implant in that spot, please?
Of course, let's consider that together. So we'll pull up
Yeah.
an implant at sign number 15. As you already noted, Dr. Pernu, you wouldn't really be attempting a 3-5 right in there. So we'll probably be considering, ideally, let's go with a 5'10" or a 5'11.5" implant. Let's try to treatment plan it in there. But one thing that we have already noted about this case, and Dr. Robinet has been talking about it, is probably what we can see right here in terms of sinus pneumatization pre-extraction is different to what is actually the case right now. So if we blow up the screen, we show you the image. Dr. Robinet, I'm using a 5.0 by 11.5, just placing it
Okay.
into this geometrical space. It looks like we're engaging that wall of the sinus, and we're exactly 1.5 millimeters away from that adjacent tooth.
Okay.
Yeah, but it's not. So the final result, actually, I have exactly, I don't even have
Okay.
6 millimeters.
Okay, that number 16, what does on this X-ray, you can't really tell from a CBCT. Does it have big restorations?
Yes, I did do a restoration from the
Okay.
moment where this CBCT was taken. And the patient is not upset of losing 16. I did not want to extract it because I figure it out that it's going to maintain the sinus position. So I chose to extract 15 bone graft.
Okay.
And I said, if I'm not getting enough bone, I can extract 16 afterwards.
Okay.
Do you think that would be what I need to do?
We're a little bit handicapped because we can't see the new CBCT. I mean, I understand what you're saying. And so if you don't have enough for this 5.0, you can only put a 3.0 implant or a 3.5 or something like that. That meant that number 16 moved a whole lot. That's kind of concerning to me. I'm one of the people in the world, I don't like wisdom teeth. All wisdom teeth belong in the garbage can. Not everybody agrees with that because I look at it, people just can't get back there and keep that clean. So I would like you to next month, because how long has it been since it's grafted?
Oh, it has been over 6 months.
It has been over 6 months.
Yes, it is fully integrated, and it looks perfect to place an implant, but I don't have the bone availability for an implant.
Okay, so you need to get one of us to Dr. Zaid or to Dr. Resnik or myself, Dr. Hussein, let one of us see that new CBCT.
Okay.
Okay, because right now we're looking in the blind. We can't see anything. Go ahead.
Yeah, but would you consider sacrificing 16 in order to place an implant on?
I would
15?
take out 16 all day long, so I can place an implant in 15.
Okay. Because I was thinking, is it to her advantage to try to go fully restorative in a situation like that, and to try to bridge it there, or am I better off removing 16 and placing the implant on 15?
Okay, what I would see if you did a bridge there, they're going to have an extremely difficult time keeping it clean between the ponic and the abutments. So I think probably within 10 years, your bridge is long gone.
Okay.
Okay.
She's young.
And-
She's in her 50s, so I cannot lose something in 10 years.
Yeah, I wouldn't do that. My first thought is the wisdom tooth goes, and then we build around that. Your thought process of keeping the sinus in the original position, it's good thinking. That's thinking outside the box. That's really, really good. You'd be congratulated on that. But I think if you're going to do anything with 15, 16 is going to have to go.
Okay, I will do, probably that's the choice. I measured 10 times and no, the sinus pneumatized even more than what you see here after the extraction.
Yeah. I would just get with one of the four of us or anybody at ITX.
Absolutely.
And let us work that up for you. Agreed, Syed?
Yeah.
Yes, agreed, 100%. And one more insight that we could share with everyone, Dr. Robinette, going back 6 months in time, if this was still the recent situation, how would you deal with the infection, the extraction, any preservation for the sinus?
Yes. Let me. This is what we had all prepared to discuss, because your floor there is so small that when you took that tooth out and you went to curette, that you're really, really careful that you don't perforate the sinus. Okay, and then make sure the assistant doesn't go all the way down there with the suction tip and perforate the sinus. Okay, but as I said on the case earlier, as big as that radiolucent area is, did it come out in one big piece for you, or did?
No, I think I curetted. It was not one big piece. But to tell you the truth, I know for sure that I managed to clean everything because I know how good it looks. But in general, if I opened the sinus, which probably, I don't remember if it happened in this case, but it happened multiple times. So I placed a membrane and I graft, nicely, and it heals beautiful after that, even if we perforate, as long as we place a membrane and we graft on top of it. I put a collagen piece
first, right on the floor.
Yes,
very good. Put the collagen piece first. Put some Ansef on it even. Put the patient on augmentin after the case. Do all that, and then you'll be in great shape.
Yeah, thank you so much. I will send the updated CT
scan. Just send the updated scan, and one of us will get with you on it.
We'll take care of it, Dr. Colonel, as we usually do. All right.
Okay. All right. Thank you.
Thank you a lot.
Okay.
Perfect. I think we got 2 more cases for us, Dr. Robinette, but I don't think the clinicians are available to go through them. So that would pretty much conclude today's session, everyone. Dr. Robinette, I wanted to thank you, sir, for this very comprehensive discussion, for all of the cases we had for today, and thank Ziad as well for navigating us through it. Thank you, everyone. Thank you, Dr. Robinette. Thank you, Ziad. See you all next time.
Y'all take care and have a good night.
You as well, Doc.
Thank you, everyone.